I'm sorry that our resident who gave this talk this morning, he could not stay anymore. So I will try to replace him. And I'm excusing each one of you who heard it in the morning, but anyhow, I'll go through it quite quickly. So we know the advantages, and we know that mitral valve repair is probably the treatment of choice in patients with degenerative mitral disease. The advantages of repair in degenerative disease over replacement is better preservation of LV function, freedom from valve-related complication, and this will result usually in improved long-term survival. There is few evidence whether second repair is superior to mitral valve replacement. So what we did, we looked at 69 patients that we had that came due to recurrent mitral regurgitation after mitral valve repair. I must emphasize this, many of those patients were operated in another hospital. Not all of those are our failures. Some of them are our failures from our own department. So of those 69, 26 underwent a re-repair procedure and 43 underwent a re-replacement. This is the patient's data showing that there was not a big difference in the patient characteristic. You can see that most of the patients were males, and the mean age was around 60. And other comorbidities, most of the patients were in New York Heart, half of the patients were in New York Heart 3 or 4, and this is the logistic Euro score for both groups. Regarding the preoperative echo, in both groups, the mean ejection fraction was normal, 57 and 59, and the ventricular diameters were also within normal limits. The causes of the mitral valve repair are variable as expected. Some of them had ring dehiscence, some of them had artificial cord dehiscence or artificial cord elongation. Some had perforation due to SBE, systolic anterior motion in a couple of patients, and unknown reasons. So these are the early results showing that one patient died from the group that underwent mitral valve replacement, and there was some differences in requirement of PEC cells, but I don't think this is significant for the topic here. And I would say that otherwise there was no significant difference between the groups within the early results. Except of the PEC cells, there were for some reason more sternal wound infection in the replacement and prolonged ventilation in the replacement. We can assume that these patients were probably a little bit more difficult, that we did not capture retrospectively. Regarding the follow-up, so this is the mean follow-up for both groups. This is the echo follow-up, and this is the clinical follow-up. Also was not different between the groups. Regarding late results, so there were 2 late deaths in the re-repair group and 4 late deaths in the re-replacement group. And 1 patient from each group required a reoperation. Both of them, these are patients that came for the second operation because of endocarditis, and both of them needed a reoperation later on. And most of the patients on the follow-up were in functional class 1 or 2, with 1 patient in the repair group that needed, except of this patient that underwent reoperation, there's another one who has a moderate MR at the follow-up. What was interesting, the most interesting finding in this small study is that when we looked at the postoperative echocardiography, we saw that unlike the patients who underwent re-repair had preserved LV dysfunction at follow-up. You see this preoperatively they had 57% EF, and postoperatively at the follow-up it was reduced to 54, but it was not significant. However, the patients who underwent replacement after the failed repair, the ejection fraction decreased over time to 42%, and this was the main finding in this study, showing also here that the ejection fraction in the follow-up was preserved in the patient who underwent a re-repair, and was not preserved patient who underwent replacement after the failed repair. Also, the ventricular and systolic diameter increased in the patient with who underwent replacement. So we can conclude that mitral repair may be associated with improved EF and greater regression in ventricular dimension compared with valve replacement, or maybe preservation of ventricular dimensions, and that repair is safe and can be durable in selected patients. Should be considered in patients who are younger than 60 years old with recurrent MR after repair. Thank you.